for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect the official policy or position of any entity aside from possibly Cash Like More Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders.
Well, hello, Matthew. It's been a while.
Yes. Hello, Stuart. This is the Curbsiders, and I believe Paul is with us as well.
I sure am. How's it going, guys?
Hi. You sound like Kermit the Frog today.
It's not just today.
Me or Paul? Oh, Paul does. I was like, I don't know.
Oh, yeah. That's kind of my thing.
Paul, how about you tell the audience, maybe we have some new listeners. Why don't you tell them what we do here on this show?
Well, new listeners, welcome to the show. This is an internal medicine podcast that uses expert interviews to bring you clinical pearls and practice-changing knowledge. In the interest of full disclosure, we also tend to mess around for about the first 10 minutes of the show talking about work-life balance, my cats, and other things. So if you wish to skip past that point, a la WTF style, that is fine, though you'll be worse off for it.
Excellent.
Stuart, anything that you wanted to bring up before we got into the guest bio here?
Absolutely. So it's been a while since we've mentioned any listener feedback, and this one really touched our hearts. So this one says, sorry. This one says, I love the way you approach medicine. Somehow you remind me not to take my profession too concerned and more relaxed. I listen to your podcast on my way to work in the morning and when I'm on my bike in the afternoon on my way to the city center of Dusseldorf. You make me laugh so often. I don't know what people around me are thinking when they see me laughing on my bike. Patricia. Well, Patricia, lucky for you, we're here to help. Hey, Paul, what are they thinking when they see her laughing on her bike?
I'm not going to presume to imagine what's on the mind of the people of Dusseldorf. I'm sorry. I'm not going to commit to that.
Yeah, let's just set up the show, Stuart, because we had a lot of great stuff here with Dr. Dhaliwal.
That's right. So once again, we have Dr. Dhaliwal back on the show by popular demand. In our last episode, we briefly touched on how to train your brain, but as oftentimes occurs, we delved into a tangential topic about the importance of and how to teach clinical reasoning. If you're interested in that topic, and we sure are, please take a listen to episode number 90, Clinical Reasoning. I've got to say it here. My favorite quote from that episode, and one which seemingly sums the entire episode up, is, everyone here is smart. You distinguish yourself by being kind. Nevertheless, the one today, will focus on training your brain. As Dr. Dhaliwal puts it, professional musicians, athletes, chess masters, and others perform for maybe 1 to 2 hours per week and spend the rest of their time training. If you are like all the rest of us in the medical field, performing all the time and spending little, if any, time training, then boy, are you in luck. We have Dr. Dhaliwal with us tonight to help us learn to train our brains.
That's right. And in case you missed his bio last time, Dr. Gurpreet Dhaliwal, MD, is a professor of medicine at the University of California, San Francisco. He studies how doctors think, how they diagnose, how they make treatment decisions, and how they develop expertise. Considered as one of the most skillful diagnosticians and clinical educators in the U.S. today, Dr. Dhaliwal sees patients and teaches medical students and residents in the emergency department, inpatient wards, and outpatient clinic at the San Francisco VA Medical Center. We are thrilled to have him back on the show, and I hope you enjoyed as much as we did.
That's right. So let's go on talking about training, because I know squat.
Did I miss a pun there, Paul? I don't get it.
Well, because if you were exercising, say, then you might be doing squats. And so it requires a little bit of work on the listener's part.
That's what they call a long walk in the comedy world.
For a short slide.
Well, here we are, back with Dr. Gurpreet Dhaliwal. Thank you so much for joining us again.
Happy to be back, guys.
Yeah.
Apparently we didn't scare him away. That's great.
And as we told you, your first episode was very popular with the audience, and I'm really excited for this one. But for people that didn't hear your first episode, how about you give them a one-liner just to remind them a little bit about yourself?
I'm a 44-year-old general internist. I practice at the San Francisco VA, and I'm a faculty member at UCSF. I am a full-time clinician educator, so I spend all of my time in clinical practice, and I spend half of my time in the emergency room, half of my time as a hospitalist. I precept a little bit in clinic. And I'm really interested in sort of how docs think. But then what we're going to talk about today, I hope, is how docs get better at thinking. And then the other things I tend to do on the side, I have two boys. They are 10 and 13. Those are confirmed since the last podcast. I do engage in a little bit of one-on-one basketball with them on weekends.
This is gold. I'm sensing a common thread here.
Yeah.
Well,
I was so nervous. You know what? I was so nervous about their ages since the last podcast that I forgot my own. The worst.
Yeah. Well, once you get above 30, I feel like you should just stop counting your age.
I totally agree. Yeah, it's immaterial.
Since we've already kind of done our usual questions with you, I think we can just ask, did you have any pick of the week, anything that you wanted to recommend to the audience? And then I'll let my co-hosts give their picks of the week if they have anything.
Yeah, I was thinking about this because I think last time we did books, and I've loved the books that people have been suggesting on the podcast. But to the extent that we were talking about last time, we're going to talk about, again, sort of achieving your personal best. I think there's a movie that I love, and my kids even got it for me a while back. It was long enough ago that it was on DVD, but it's still relevant. They got me this movie called Jiro Dreams of Sushi. And it is about an amazing sushi chef, arguably one of the best in the world, if not the best. And it's beautifully produced. The music and narration is amazing. But the greatest thing about it is just watching someone who loves his craft so much that he's dedicated himself to getting better and better and has no notion that he's achieved perfection. He just is on the path to trying to find it. It's both serene and inspiring. And, it's the mindset I would hope all of us could have for our craft as being doctors.
Yeah, it is.
It's a great choice because most movies, usually if you are obsessive about your job and your work, that possesses an inherent character flaw that gets in the way of relationships in life. So it's actually nice to see it framed in a different kind of context.
Well, a lot of that's cultural as well. So the Japanese culture really kind of instills that idea that you want to be the best at your craft.
His mindset is very devotional. Yeah. Have you seen it?
I have, yes. It was on Netflix for a while. I'm not sure if it's still available on Netflix, but it was.
I think it might be on Amazon Prime. I'm not sure, though.
Paul?
If any listeners want it, I have the DVD. You can just I'm going to ship the DVD if anyone has a DVD player left.
No, I don't think anyone does. I think we gave up on those. Paul, do you have any questions? Or picks of the week, rather?
Many questions. I do have a pick of the week, too.
I question your pick of the week.
So I'm going to actually recommend a podcast. It's this podcast called Unspooled, and it's hosted by Paul Scheer of How Did This Get Made fame and movie critic Amy Nicholson. And what they're doing is they're actually going through all the movies and the AFI's top 100 movies of all time. So each week is dedicated to one movie. So rather than reviewing bad movies, they actually watch a movie that the American Film Institute says that everyone should have seen. And just sort of talk about it for an hour. And I don't know if you ever heard How Did This Get Made? It's a really funny show. I like it a lot. But to actually hear Paul Scheer talk with genuine passion and interest and be serious about movies that he likes it's fantastic. So if you're a fan of movies, I'm actually following along and watching the movies they recommend week by week. So I got to see what was it called, Swing Time, which is a Fred Astaire and Ginger Rogers movie. The French Connection was just on last week. So it was a chance to kind of even build my movie backlog even further. So if you like the movies, it's a great podcast. It's called Unspooled.
Excellent.
I'm going to check that out, Paul. You are my number one podcast recommender, and usually I like them, so I will check that out.
They are categorically non-medical always.
Yes.
Excellent. Hopefully the movies are too. So my pick of the week is something I've been wanting to say only because I've got 5 kids with lots of holes in the wall. It's called Durham's Rock Hard Water Putty. Highly recommend it if you have kids of any shape or size and or holes in the wall. It's kind of like putty, but you can use it to fill wood or plaster or anything, and you can sand it or paint it. It's amazing.
Yeah.
My grandfather swears by it. When he showed the package to me, it looks like something from the 1800s, but it works. It's miraculous.
Yeah. I think it's maybe early 1900s packaging. It's like a guy in a wrestling singlet, like flexing.
Yeah.
But
it looks really funny and campy.
Yes. I have used it, Stuart, for a coffee table and a bookshelf project, woodworking project, and it worked great. So
here's what it looks like.
There it is. Stuart's sharing his screen, which is fantastic for the podcast audience. It really works well.
I'd like to revise my pick of the week. I think a jump rope. $5 jump rope at Amazon.
I'm not going to do a pick of the
great.
week. I think we should just move into the topic at hand. And Stuart, I think you have a clinical case.
That's right. For once, I have one. So here's a clinical case from Cashlack Regional. So we've got Dr. Know-It-All. He's a junior practicing physician with privileges at the Cashlack Regional Ambulatory Practice, or CRAP for short, who earned higher marks in residency but feels unsure about himself and wants to know what he can do to prevent what he sees as common pitfalls, those being misdiagnosis, premature closure, and interpersonal communication lapses. So Gurpreet, at the end of our last discussion, you briefly touched on your training regimen that you focused on. So you spoke about 4 distinct concepts, those being feedback, simulation, microlearning or quizzing, and learning from consultants. So Dr. Know-It-All seems to be in need of some training. Could you give us a brief overview of those concepts that underpin your training regimen?
Yeah, and I certainly want to help. I don't want to be a know-it-all, but I certainly want to help Dr. Know-It-All in their pursuits. Yeah, I think, what I think about, of course, is like when we're in practice, we're busy all day long. And the question is, we owe it to ourselves and we owe it to our patients to get better and better. And there's just 2 paths. You can either say, I'm going to go to work and try to learn what I can from the job, or you're going to say, well, can I create a program that takes a little extra effort, but allows me to get better, puts me on sort of a different performance curve. And some of those things that you mentioned, like feedback, which we talked about the last time, tracking your patients is something you can do to learn from your cases. You can set up quizzes for yourself. You can do simulation. But I wanted to step back from those 4 things and think about, like, what do any of them do? And as I've been thinking more and more about this and really helping my trainees get better, help my colleagues get better, and myself, I recognize that, what we're doing at work is we're getting exposed to a ton of cases. Like we're trying to expose ourselves to cases and we're trying to learn. And that winds up being the very best way of learning and developing expertise. And it's worth noting because there's a lot of other theories would tell you that there's something else to do. Like some people might say, well, stop falling prey to heuristics and biases. And someone else might say, no, you just should keep up with the literature. And, someone else might have a different theory about how you become great. But it's shown over and over again in fields that if you want to get better at a domain, you have to encounter real problems for the domain. So I started thinking about, well, what can I do to put more cases in front of myself? Like, and this is an odd question, right? Because docs are really busy. Like we work 8 to 10 hour days. So you have to ask yourself, am I going to really draw inspiration from these other fields like deliberate practice and other ones where the world is exactly the opposite? Like in chess or music or sports, they train all day long and they have like an hour of performance once a week, right?
Yeah.
And our world is the exact opposite. We are performing all day long and you're saying, where and what can I do? And maybe a half hour or hour I could eke out every other day or a few times a week. So that's the dilemma that we face in trying to optimize our performance and judgments and thinking as physicians.
So can you use your practice? We spoke about this last time. Can you use your practice specifically as a form of training?
You can. So the thing that we touched on last time, and I think is worth emphasizing, is that the core series of cases that you have are the ones that come before you. Mm-hmm. And so the big differentiator is the clinician who goes to work, does their very best, and reads if they have to figure out things, but otherwise just hopes that over a period of years and years, by seeing a lot of stuff, by reading as needed, by running into colleagues, I'm going to get better. And the answer to that is that you will, but you're probably not achieving your maximal potential. And so if you just stuck to your raw cases, just the anywhere from 10 to 30 cases you might see in a given day, there's a subset of clinicians who put in extra effort around those cases. So they're just as busy as everyone else, but they will track what happened to that patient. They will find a way to read on the margin of their knowledge, even if the case is sort of quote unquote routine. Like, someone may have another case of diverticulitis, and for most of us, that's another case of diverticulitis. But someone else says, let me just go to UpToDate and see what's new there. And they'll realize, like, oh, now people are using NSAIDs for mild diverticulitis. I didn't know that. But if I had just registered it as a quick case, I would have done it. Or they're sort of finding ways to learn from colleagues. And over the years, I found that's one of the hardest, but one of the most beneficial things to do is actually extract learning from your colleagues.
So I wanted to briefly touch on about following up on your patients, keeping a patient log, because I thought this was interesting last time that we talked. We talked about keeping a patient log, and I queried the residents that I work with. We've got about 90 residents. I think at this one morning report or conference that I was at, maybe about 50 to 60 of them were present. And I asked them pointedly how many of them kept a patient log. And interestingly, only 3 of them said that they did. Does that surprise you?
No, I'm not surprised at all because, and it's a precursor for everything. Like everything that we're going to discuss today is more effortful. So we're talking about an odd thing. We're talking about asking like really busy, whether it's trainees or physicians, to put in some extra effort for the goal of learning. And then I will tell you, it's extremely effortful to track your patients. There's everything from recording the name, the number, the question that you had, knowing when you need to follow up, keeping it in a HIPAA secure environment, carving out the time in the future to track what happened to that patient, sometimes then finding information that creates more work for you. It's quite effortful. My only point is it's very rewarding, but I'm not surprised that any sampling of doctors wouldn't do it.
Yeah.
So practically speaking, what does that look like for you? Is this an Excel spreadsheet? Is this how are you actually keeping track of what to keep track of even? Because I imagine with the volume of patients you see, you're amassing just a huge patient log.
Yeah, and the thing that I've gone through many iterations, and the subset of people I know who do this have all said the same, that you're trying to figure out a method to do it. And I've gone from everything from Post-it notes to black books to Excel spreadsheets. Increasingly now I found, and on my iPhone, et cetera, but I think to attend to HIPAA, convenience, and actually to catch me where I'm at, I think you have to have the tagging system in your EMR.
Yeah.
And there are different, all our EMRs are different, but some allow you to create shadow lists. Some allow you to send emails to yourself to remind within the program to remind you to check the chart in 3 months when the serology comes back, or in 3 weeks when that mycobacterial culture should be pos or neg. And then, right, and because otherwise you never know. You never know if that was or wasn't. And I think that is going to wind up being the functionality that, EMRs weren't really designed with docs in mind, but if there's one thing they could help us in learning, it'd be answer the simple question, what happened to my patient?
Right. One of the common questions that I get is, how many of these patients should you follow? All of them, some of them, half of them?
No, unfortunately, the answer should be 100%. The reality I learned super quickly when I was working for a nocturnist for 10 years, that's when I got this habit, was that you can only follow a fraction of them. I should differentiate. We're not talking about patients you're responsible for. That's something very different. So if it's your clinic or it's your patient, if you own the patient, then we're talking about an ethical responsibility. But we're talking about learning when a patient may have left your care. You discharge them from the inpatient service, you discharge them from the ED, you gave phone advice and told them to follow up with their primary care doctor, that sort of thing. It's overwhelming if you aim for 100%. I honestly would say that even my rate is, and I love this habit and I don't do it perfectly every day, is probably on the order of 5%. It's only a sampling that I'm doing because it ggets overwhelming. And I actually learned the best part about it I learned is that I thought that you should do it for just the rare or tricky cases. Like I had a case with a person who wound up being a subarachnoid hemorrhage, and I'm very interested to see what's happening for him. And I had a case that I think is sepsis, but I wasn't sure, and they spiked a fever right as I was signing them out, so I'm definitely going to track that one. But then I just packed someone's abscess. I did an IND of an abscess, and I drained it, and it was completely routine. And I said, just follow up in clinic. They'll do the packing. This thing is going to be great. Things are going to go swimmingly. But I never would have tracked them except I just put them on my random list. And I found out 2 days later, the abscess, which I thought I had done a terrific job draining, was twice the size and was extending. But I wouldn't have done that. That was just on my random tracking list. I said I should just sample the quote unquote routine easy cases. And what I learned was it wasn't routine and it wasn't easy. And I'm going to do something different the next time I have to drain an abscess like that.
What's the longest that you've tracked a patient?
Oh, yeah. The longest I would say is when I set out intervals like, was the mass cancerous or not? So check out for 3 months. Or we've done something like treating a chronic infection. I want to see if that osteo is eradicated. But I will tell you that after 3 to 6 months, it's hard to really track the patient because there's so many other ones that are entering your system.
Right.
It is a really rewarding habit, but it's a very taxing one. My colleague Sarisha Narayana, she created a curriculum in our residency for the interns to do it after they've discharged patients months after being in the hospital, and we published this in the Journal of Graduate Medical Education. And they found there were lessons that you would never imagine when you do check people months later, like survived or did not. Was solved by the rheumatologist, not the infectious disease doctor we sent them to,
right.
et cetera. But I think the practicality of it is, and one more thing is that when you track really long out, your brain forgets what was the question I had. Right?
Yeah.
If you say, I just wanted to see if that, I just want to see if that blood culture was positive or not, that answer happens in 72 hours. Like I discharged someone from the ER who had a kidney stone, but had a white count of 18,000 and had pyuria, but clinically did not look like it was infected. And a lot of my colleagues said, I always give antibiotics. Some people said I didn't. And I said, no, my flavor on this one is I don't think this is an infection, so I'm not going to give him antibiotics. But in the back of my mind, I was like, I'm not 100% sure on this. So I gave him full assurance. I'm like, sure, you're going to be just fine. Don't you worry. And then I wrote his name and number down. And I've been tracking his cultures. And in 72 hours, it resolved the question in my mind about, can you have a high leukocytosis and pyuria without an infected stone, which the answer is yes. And the literature search was hard to verify that. So short is better because the question is clear in your mind and the queue hasn't built up much.
Something that you mentioned last time, and I think this kind of goes along with the tracking your patients thing, is like your brain, you don't know, a lot of the times when you're wrong, I think you might have been trying to answer the wrong question, and you said like your brain can't solve the problem if it's trying to answer the wrong question. And one of my colleagues at Kashlak mentioned there was this male patient on their service, had this horrible abdominal pain and ascites, and they were doing all this stuff to work it up. And they never considered that it wasn't actually ascites, it was urine. And the patient had a perforated bladder from from many years ago. The person had some procedure to the bladder that had weakened it. And so, yeah, you gotta, if you had gone off service and you had been treating that patient and not looked back, you might not have known that you had missed that this was not ascites, it was urine that was causing all these symptoms.
Precisely. Yeah. You go from saying, oh, this is my 100th cirrhotic ascites patient I've seen to this is my N of 1. This is my first urinary ascites. And you sort of open up that file in your mind. You get a piece of humble pie and you open up that new file in your mind. You're like note to self on occasion. And then you do have to go back. You have to say like, well, what are the reasons people can get urinary ascites? And you start to say, oh, well, previous radiation or trauma or other surgeries may have accounted for it. And so then the next time another patient who looks like their liver and has ascites there, you should still think it's likely going to be ascites, but you might take note like, oh, I realized they had a bladder surgery also 3 weeks previously.
And my follow-up question to that is, so me speaking with her, I didn't see this case directly, but now, hearing that case, now that's sort of on my differential. This is sort of, we talked about illness scripts last time, and problem representations. For an illness script, this is sort of for ascites now, this is on the margins, like I'm kind of broadening it. Is that what you meant by learning from your colleagues?
Well, yeah. So the learning from the colleagues is another dimension that I found really interesting. So one is sort of giving feedback. It is tricky to call up your colleague and say, hey, by the way, I have no reason to call you. I'm just calling you to tell you you're wrong. So
that's hard.
It is hard, even if it's meant with the best intentions, because there's a lot of times when I made mistakes and I'm certain people are not calling me, and I've seen mistakes other people have made, and I'm like, boy, I know they love to learn from this thing, but I want to find a graceful way to tell them just for their learning. Like there's no gotcha in it. And I started to recognize that there are fields where they study when is it okay to give people a little bit of negative feedback or constructive feedback. And one of the best insights comes from an old study in Harvard Business Review when they talk about high functioning teams. And they said high functioning teams don't hesitate to give each other negative feedback, but they have an offsetting ratio of about 5 positive comments. So on these teams where they debate and we'll talk about things and say, listen, you should have done this differently or things could have gone another way, it's only in the context of having had roughly 5 offsetting positive comments. And they may be affirmations, they may be jokes, they may be favors, but whatever it is, you have a very positive mental bank account with that person. So that if you do want to call them back and say, hey, your patient's here in the ED, and I just wanted to let you know that we were all calling that appendicitis. It turns out it was all a psoas abscess. They're receptive to it because they know you and you guys have had generally positive interactions. And so I've been thinking about this as trying to build relationships with people who I hope would give me negative feedback, or I could give them constructive feedback on it, is that you say, like, listen, let me just talk to this person about a case and learn from them and give them some appreciation for what their resident did, or their consult that they came in on a Saturday afternoon and helped us with. So then I'm building up that positive bank account so I can give them feedback or expect them to give me feedback, because they're essentially friends instead of transactional colleagues.
Mm-hmm. I like it. Did you make up that bank account thing just on the fly there? That's good.
I'm trying. You know, I think
it's a common thing.
Yeah, I think the emotional bank account may be from Stephen Covey's The 7 Habits of Highly Effective People.
Okay.
There's a relationship book that talks about banking. Ah, man, I can't remember what the book is called, but I think it actually predates The 7 Habits of Highly Effective. Yeah.
Because, I mean, usually banking is a source of discourse in relationships. What's happening with the banking account?
So do you not run the risk
by the way, I should say that, speaking of relationships, that 5-to-1 ratio turns out to be true in marriages as well. John Gottman is this marriage expert, and he talks about that. He says, just like all teams have negative comments, he says all couples fight. He's like, it's just the number of offsetting positive comments that determine sort of a high-functioning couple.
But you don't run the risk of diluting the feedback then? I guess that'd be my concern. It's almost like the compliment sandwich. We're so hackneyed.
No, the thing is, it's not the compliment sandwich or the feedback sandwich. So it's not like you're that Machiavellian. You're like, I'm going to plant 5 positives so that I can drop that negative on someone. It's just much more like it's almost like be nice to people and cultivate these relationships. There's times when you need to do stuff that's a little less pleasant, but the two of you grow if there's a lot of, and now I'm not talking about relationships. My wife would laugh if I was brought on the show. But the two of you as a dyad of physicians who work together in a hospital, both of you grow when you're giving each other. An example, this is really, really just another telling thing. I had a patient who the EKG machine read AFib. And I was like, boy, this looks like normal sinus rhythm with PACs. Really trivial, right? But I'm an internist. I want to make sure I don't miss AFib. And it's kind of tricky, and the patient had left. So I tagged the chart. I found out that our cardiologist did read it as AFib. And I said, oh, man, I'm pretty sure that this is normal sinus rhythm with PACs. But because I know the cardiologist really well, I sent him a secure email and I said, hey, blank, do you mind checking this? And he emailed me back and he's like, you know what? You're right. I overcalled it. This is just normal sinus rhythm with PACs. The only reason I could ever challenge a cardiologist on their EKG read is because I have a very positive relationship with this person. And, this person may count this as a negative, sort of I corrected him, even though it was very cordial. But the point was, if I didn't know him, the EKG would have never happened and I would have never gotten the learning and neither would have he.
It's actually, for me, not that anyone cares what I think so much, but it's for me, one of the benefits of being a cash slack for as long as I have is having developed relationships where I can approach people without ego and ask, yes, what did I do wrong? Or would you approach this again? Or could you look at this a different way? To not be scared of actually approaching people and to do it in the service of the patient learning. It's probably the best change that has happened in my tenure at my time there. So rather than being afraid, realizing we all have the exact same goal and just having a conversation has facilitated care so much more than being scared to ask.
I would tell you that I think people start to get used to, you're the guy who asks learning questions, right? Yeah. So a lot of our work is transactional. They're like, start steroids, keep this person NPO, we'll cath him tomorrow, and it's very transactional. And if your interest is not the what, because in medicine, the what starts to become easier, familiar, but you really want to understand the why. We took care of Mr. Smith last week at Cashlack, and he got heparin for his troponin elevation, but then Mrs. Jones came in and she didn't. I understand I will start on one and not the other, but I want to know the why. Is only if you know them. And I teach the trainees is sometimes it is hard to ask the why because another person may think that you're threatening or questioning them when it's really just inquisitive. So I say you just got to blame it on someone else. If it's the student or resident, you say oh, I'm happy to start the heparin, but I have to explain it to my attending or my team. Would you mind explaining to me why we're doing that? And then I pull that all the time. I'll say, that's great. Listen, we're totally happy to send those serologies and we'll start the cyclophosphamide. But, just so I can be clear when I explain it to my team, do you mind telling me why? And I'm doing air quotes for my team, but they can't see that on the phone.
It seems to me that this would be the natural outgrowth from effective peer review, but oftentimes I find that peer review is more pencil whipped and just kind of on the back burner. Is this kind of like just effective peer review?
Okay, I don't know what pencil whipped is, so I want. Is that something good or bad? But no, it's definitely different from peer review. This is, I mean, it's so casual and about one small element of the case rather than a global assessment of how someone did. That I think that peer review is in a separate category. But to the extent that we're comfortable talking about each other, I think the dividends are so great because at some point you go beyond the evidence and you're just trying to learn. Am I doing this because it's your style? That's the way we do it here at Cashlack. Or are we both not aware of some literature where we should be doing this better?
Can I ask, I want to throw this out, and I don't want to take too much more time on this because I don't want Stuart's head to explode. But I just want to throw this out to the group. Do you guys run the list with the people that you pass off your patients to? Because that's something I do commonly. The next attending that when I go off of service, I will call 2-3 days and just be like, can we just run the list and tell me how these people did and what kind of happened? Is that part of your routine practice too?
When I come back so as a hospitalist, I'll have patients. I'll come back after my time off and I'll ask about some of the patients. And often I have started creating lists. So a lot of the times I'll have checked on cases that I was interested in, the outcomes. But I don't know that I'm as good about it as I probably should be, as systematic as how many days later are you doing this, Paul?
Well, it's probably, since I'm not a hospitalist, I'm going to be there anyway. It's probably a little bit easier for me too. So like I'll be there 2 or 3 days later and I'll just call the next attending and just sort of check in and literally go through the list that I probably still have in my white coat pocket and just, was this person septic? Did they go home? Is this person walking now? That kind of stuff. Just because I like self-flagellation. There's something satisfying about looking at that scan. So I don't mind hearing about my own mistakes so I can do a little bit better. So yeah, I do that fairly routinely.
I would I heard that one of my colleagues that worked very closely with Andrew Olson, who's a med peds attending at University of Minnesota, he talked about a colleague who pre-warns when he gives a service over. He's like, when he takes over a service, he says, I'm going to be calling you in 3 days to tell you how these patients have done. And I heard Andrew present that at a conference, and I thought that was great. Amazing because that outgoing person puts it on their to-do list and he pre-warns so that it's a given that the call that's coming in 3 days has no judgment around it.
Right.
There's going to be some successes and there's going to be some mistakes, but it's so clear, like I'm calling you for learning and so that we strengthen our relationship rather than out of the blue, like, hey, text, want to let you know that culture was positive. Should have started antibiotics.
Right.
It's a much higher level communication.
That's fantastic.
Yeah. In the EMR that I use, it's not really the patients that I'm more concerned about because I can follow them. I can look at them and see what the outcomes were, at least by just kind of perusing through the chart. What I actually call back about is more about the learners to see if they followed up with the things that we had counseled them on or where they're going as learners. So I'm looking more at the learner as a patient in this case as an attending more than the patients as patients. It's probably a failing of mine, but it's something I like to do.
I think we should move on to the next topic, which we're talking about quizzes and microsimulation. And
That's
Stuart,
right.
I think you had a little more of the case here.
Yeah, so Dr. Know-It-All has taken your feedback to heart. He's still having some difficulty finding enough cases to further his training. He started using the Human Diagnosis Project at humandx.org, but wants to know why simulation is important. So while it seems like a no-brainer, and I know you mentioned this previously, I think in the last time that we talked, that pilots use flight simulators. Most pilot schools, or at least many that I looked into, they actually don't use flight simulators. They actually do side-by-side. So, for example, in my first 10 hours of pilot training, I actually sat side-by-side in a Cessna, I think it was like a 172 in the early 2000s. Similarly, in the medical field, replacing actual patient encounters with simulated computer-based training might seem suboptimal. So why is simulation in the medical field important?
Yeah, I think I use simulation almost in just the low-tech version of it, which is putting your brain through the paces. So there are super high-tech simulators for cases if you want. But when we're getting back to sort of how do I train myself, we did this first section, which I like, which is like from the patients I have, what can I do? I can do feedback. I can learn from my colleagues. I can do a little more reading on my own than I would have. That's one bucket of cases. But if you follow all the literature, like on naturalistic decision-making and expertise and judgment, you find that people find a way to put themselves in front of more cases. So it doesn't have to be as authentic as like a real-world simulation exercise. It just has to be a chance to practice either solving a case or learning from a case. So that's why I use the word sometimes micro-simulation, because in the past it might have been what can I read, but really now multimedia, there's so many chances to put cases in front of your brain, and some of them are very short, some of them are medium length, and some of them are full length. And I would say that's almost that's the underpinning of a great training program, because doctors are very busy, and if you tried to learn as much as you can from your own cases, the amount of reserve you have left to learn from extra cases in the universe is small. But luckily, there's a menu of sort of small, medium, and large. There's like this Goldilocks options, and that's what I think it has a tremendous amount of potential. The full-on simulator would be something like, it could be a virtual reality sort of thing, but I think there's these long cases that come in the New England Journal of Medicine, for instance. They have the weekly clinical problem solving or monthly clinical problem solving case or weekly clinical pathologic conference. Or they have an online analogy, which is the interactive medical case, where you really go through a long case. There's tons of embedded reasoning you can solve as you go along. But you honestly have to block out about 45 minutes to do those properly. But they're available, and I am religious about doing the paper one that comes every week. But I think the real promise for how busy everyone is, and I certainly find I guess my favorites now, is all the small cases you can expose yourself to constantly. You just ask yourself, how can I get myself in front of a ton of cases?
Yeah, I love it. I started, I haven't done the long case in the New England Journal as much as I would like to, but that was one that I hadn't gone through that, because it's kind of like, it is, I would read it and I'd be like, oh, I can't get this case. Like, I don't know what's going on here. But now, like, when I look at it as like, okay, this is a game, I'm training. This is gonna make me better there's going to be twists and turns in this. And, if it's a game you can win every time, you're probably not learning. So, yeah, I think that's been great. And then we are not sponsored by humandx.org, but I just think it's a useful tool. That's why you brought that up last time. And that is one that you can use. And yeah, the cases could take anywhere from a minute to 5 minutes, but they're very quick, and they're written by other internists from just all over the country.
That's correct. And I think those are two extremes of sort of the long case. And I want to follow up on what you said about that. When any of us do the New England Journal of Medicine CPC, like there is a moment of futility where you're like, there's no chance that I'm going to get this. Or I'm so far afield, I can't wait to see what someone smart thinks about this case. But it underscores, like, if you're really trying to train your brain, it's what you said. If you can get it, you're not really learning. Like you want it to be, learning should be really effortful. One of the greatest notions I love about learning is like, it says sort of when the demand exceeds the supply of your neurons, that's when learning happens. Like it outstrips what you know, and that's exactly what you want. And the thing about these long cases, whether it's in that journal or any other one, is that the final diagnosis is rarely the thing of import. It might be an unusual genetic syndrome or an atypical presentation of something. It's much more important how they ruled out, that this was not lymphoma, so that you upgrade your knowledge of lymphoma, or that they recognize, like, this is the way strongyloides presents, and that's why they didn't think it was a parasitic infection. So you take away those things. It's a very much journey-like. If you contrast it to the short cases like that you can do on the Human Diagnosis Project or on Medscape or Figure One, or even shorter, like things that you see on Twitter, right? I mean, Twitter people post de-identified short cases, sure, but the learning happens instantly. I mean, the learning is in 30 seconds. You're like, I put myself in front of a case of a giant coronary artery aneurysm. I put myself in front of a case of a fever and a rash that winds up being rickettsial disease. It can happen in 30 seconds.
Yeah, this is great. So I would tell the audience, it helped me to think of it as kind of like a game, and that you are leveling up. And I don't know, that I need to do that. It's kind of like a hack for me, a life hack, if you will.
Yeah. That's the mindset. The phrase I love, it's sort of, maybe it's getting too sports or militaristic, but it's sort of the notion you sort of sweat and practice so you don't bleed in the game. It should be incredibly effortful, and it should be really humbling, and it should be at the margin of our knowledge. And then there's this hope that it sticks in long-term memory. Maybe we'll talk about that later. But if you don't get yourself in front of those cases, there's little hope of it even starting at that point.
Stuart,
and we're very lucky in this age where all those cases are around.
Yeah. Stuart, where are we going to go next with this? What's the next?
Yeah, so I think we've adequately addressed the whole idea of simulation. I think the next question that we have is more along the lines of microlearning and quizzing. So Dr. Know-It-All has some questions specifically about that and how it varies from simulation. So how does this vary from simulation?
Yeah, so it sort of gets at, if you're going through this effort, whether it's learning from my patients on the job or some extra time I find reading, and oftentimes it is a life hack, like you're doubling it with your commute or doubling it with your exercise or while you're sitting around. But if you figure out a life hack to get yourself in front of some more cases, then the real question is like, it's sitting in short-term memory, but the chance that I'm going to be able to recall it when I'm taking care of a patient or teaching it or something else is actually really slim. And that's very depressing, but that's because our brain immediately, the minute you upload something great, and however great it is, it immediately starts on what's called the Ebbinghaus forgetting curve, which is just this exponential decay where it starts to forget knowledge that was in short-term memory. And it also is the same with long-term memory. And your question is, what do I have to do to take this pearl that I just learned or this insight I just got from this case and shift it into long-term memory so that I can retrieve it again when I have to teach it or see a patient or draw on it for something else. And that's when you have to create some extra challenge from your brain. And I know that sounds effortful because we already talked about reading more cases, but there's actually one more step to consolidating it in long-term memory.
So what is that step? I mean, is there, or is it when actually?
You like my cliffhanger?
Actually, before we go to the
episode of the Clip.
Yeah, before we go to that, we're talking about question banks here and CME questions after you read articles, things like that. Is that what we're talking about with the quizzing?
To some degree, that's it. Any way you can find to test your brain. So when we read something or hear something, what the brain thinks is that it's familiar. You're like, I just sat through a great Grand Rounds. I just had a great Curbsiders podcast on liver tox. I remember a lot of the pearls he said. What are the 7 signs of liver disease in the hand? That the liver biopsy only samples 1/30,000th of the liver. Those things are in my memory. There's a real good chance in the next week or two I'm going to start forgetting that. So what are ways that I would re-upload that into my memory? One would be what I'm doing just now. I just said it on Curbsiders. The second is I could go to the show notes and expose myself to it, and read the PDF and see if those things are there. But you can really create a lot of micro challenges for yourself. You could say, listen, I'm just going to draw out a linkage of concepts that I got from that podcast just for myself. So I write down what I know. And if I throw away that sheet, it'll still be helpful. You can say, hey, listen, tomorrow when I run into my colleagues, I'm going to tell them that I listened to this podcast, and I'm going to tell them the 4 things I want to commit to memory about cirrhosis that I learned from that podcast. You can say, I'm going to teach it. So there was a great, the show on the knee exam was terrific. But you say, I remember the doctor was talking about the 4 buckets that you put knee pain into. The only way I'm really going to know that is the next time I have a knee pain case, I'm going to use that to teach it to someone else, to my resident clinic or my nurse practitioner I work with. Otherwise, there's no chance I'll remember it. And then for all the stuff we do read now, there's tons of ways to quiz yourself. CME questions that come afterwards. Even if you don't want the CME, you just want the quiz that comes with it, or some cases have quizzing embedded in it. But the bottom line is there has to be some post-processing of the information. Just feeling familiar is seductive, but it's deceptive.
Yeah. Yes, definitely. I can say as someone who has made lots of show notes in the past several years, it definitely helps. And then going on rounds, going into the clinic and teaching it to colleagues or to students and residents, it helps consolidate all these things.
Yeah.
And that's a big reason why we keep doing this.
You're almost looking for excuses to draw on that thing that you learned the first time. Like, maybe I'll debate a friend. Maybe I'll listen in on someone else's case where they're talking about it. Maybe the next knee pain that seems totally routine to me, it's another OA case. I'm still going to go back and check those show notes real quick for one other thing so I can reconsolidate and then move on in clinic. But you want to have some other reason for the brain to re-engage with the material. And again, I want to treat this just like the feedback. 95% of what we do, you won't be able to do this. It's just a small habit of trying to do it a little more often. That's all we're talking about here. So it's not the folly of, now every case I'm supposed to go do something else after. Negative. The vast majority is still just get the learning you can out of the case, but start thinking about the ways you can re-engage with it one more time.
Love it. I'm realizing now that we didn't ask you about your approach to reading the literature, which I know is a little bit different. So can you tell us how you approach the literature when you're reading it?
Yeah, I'm happy to. I love the medical literature, but I do play favorites. The favorite I like is the cases that we were talking about. But Howard Slotnick years ago did research on how docs read, and he said there's patient-based reading, which we talked about, and then there's general reading, which is just sort of when you're perusing to try to increase your knowledge, not knowing the day when you're going to call on it. And when I was in training, what we were taught was that should just be this rigorous review of the primary literature that's coming out, that you were scanning it and pruning it and analyzing it and then uploading the latest literature. And that sounded great, but as soon as you got into practice, you recognize that a lot of research isn't practice changing. It's communication between researchers and doesn't distill down to the practice level until there's been multiple iterations and debates and such. And I came to recognize that given how limited time a clinician has, especially if you're spending part of your reading time reading cases, was that the key isn't scrutinizing the primary literature. It's just being aware of the primary literature. So it's very different. It's not, I don't need to know all the articles. I just need to know about the articles. Yeah. And one of the best ways to know about the articles is in the secondary literature. So that's where I spend my general reading time.
So I shouldn't have read all 150 pages of the new blood pressure guidelines.
I'm sorry, that's 500 pages, so clearly you didn't read them.
Selling yourself short, man.
When you say secondary literature, do you mind telling me exactly what you mean by that? Because I just want to make sure that I'm understanding.
For sure. I mean, it's oftentimes places where people who have better knowledge, it's people who have better knowledge of the domain of the literature or of sort of analyzing articles have already gone through it and made a summary and a take home. And I'm not apologetic about not being completely masterful in knowing research methods or trial methods. They're very complicated. Like there's a reason the JAMA User's Guide to the Literature is 800 pages long. Yeah. It's a field by itself. So I look forward to sort of first watch every morning in my inbox that summarizes a couple major journal articles, or Journal Watch or ACP Journal Wise, or just seeing the e-table of contents of the journals that come through. There's podcasts that summarize it. Twitter sends out the titles or punchlines from articles. And that may sound like I'm shortchanging myself, but I view it completely the opposite. I sort of have 4 or 5 inputs telling me like, hey, there's an article that says now clopidogrel is good for this. Hey, there's an article that now says, you can use BNP to diagnose this version of heart failure, or that now we use HRCT to diagnose this form of interstitial lung disease. I don't need to know all the details. I just need to know that knowledge exists so that when a patient or a teaching moment comes, I'll know where to find it. In fact, I'll even know to go looking for it. But I don't deceive myself into thinking if I read something on this day and digest the whole article that I'll know it, 12 months later.
I have hit upon the same tact as you, because I get the same New England Journal and the ACP send out a lot of great stuff, the Annals, ACP, and I just kind of scan through those things. So I've been sort of doing the same type of thing that you have, and it seems to work. When something comes up, I know that's been there, so I can go back and look more in depth when it's relevant to a patient.
I am quite frankly shocked, since this is someone who I know actually used to calculate his own numbers needed to treat when reviewing review articles.
I don't think I ever did that.
The theme I hope you get is that the key is multiple small feedings for the brain rather than extended exposure. So if it's a case, I'd rather read the case. Let me give you the New England Journal of Medicine as an example back to cases. I'd rather see it in the e-table of contents, read the summary that comes in the, I think they have Resident 360, see the summary that's sent out on Twitter, and then read it myself or vice versa, and have multiple, and do the CME questions, have multiple exposures to that one case. The same goes for the journal articles. I'd rather know that someone did a trial on whether injections work for lateral epicondylitis or not in the BMJ, and see it once in a Twitter feed, see it once in Journal Watch, see it once in the e-table of contents, and then just be totally aware that I will Google BMJ lateral epicondylitis steroid injection and learn it in depth when the moment comes. But don't take up any real estate in long-term memory before then.
Yeah, you'll just be drowning if you try to read all these articles. So
you're setting yourself up for disappointment.
Yeah. I don't think that's taught. I don't think that's taught early enough. And this is something that I talk to students and residents about, or that they ask me all the time. Like, what are you reading? What do you do to keep up with the literature? And, so I think it's great to hear you give this information to the audience. I think it's going to be really helpful for people.
Yeah. I don't keep up with the literature. I just try to be aware of it.
Yeah. All right. Stuart, what's left in our training regimen here that we need to ask about?
Well, it's something we already talked about, and it's about how Dr. Know-It-All can learn from his consultants and or colleagues. So I'm not sure if there's any more to add to that, actually.
I just want to share one global thing about sort of putting yourself in front of cases, because I do view it as it's the raw material. Like, you become expert in this by having experience and reflecting on it. That's the bottom line. You become an expert in a domain by having experience, but also reflecting on it. And so in my own personal training program, I think of 3 buckets of cases. They're the ones I deal with me and my trainees, the people who are in front of me. There's this whole multimedia universe of cases that I'm just somewhat systematically and somewhat randomly sampling, like a handful of apps, a handful of blogs. Mm-hmm. There's some podcasts, like on the I Am Reasoning podcast. They sometimes go through cases, and I learned a ton on eosinophilic meningitis because of that, for example, recently. And then there's the cases that are of my colleagues, and they're in my world locally if I choose to go there. It's a little bit of effort. But in a teaching hospital or in any hospital, sometimes there might be a morning report or peer review or M&M or a clinic conference, whatever you call it, where people are discussing cases. And it's an hour of your day, right? You're making a commitment, but what you get out of it is there's another series of cases. So there's a third flow of cases that are coming into my training routine. So my cases, the multimedia cases, and my colleagues' local cases is such a rich input. And then from that, I'm trying to figure out what are my hacks to put it into long-term memory so that I can call upon it later. That's the workflow of this training routine.
Now, the long-term memory, we've talked about it a little bit. Is there anything else you wanted to teach us there about how to get it into the long-term memory other than what we've discussed already, or are we ready to go on to take-home points for the audience?
No, I think with long-term memory, the key thing is, there's actually very interesting math and theories behind it, but they all come to the same thing, which is memory decays over time. So as time passes, the memory fades. But the strength of the imprint and then the number of times you can re-expose yourself is what strengthens the memory. So that's the battle. It's the battle of how strong the imprint is and then how many times you can do it, contrasted against the amount of interval time when there's no exposure at all. So you might say for a concept like multiple myeloma, like the time I can see multiple myeloma and make it memorable for me. Like I remember the patient's story. I taught my team a little about it, and I did feedback to see how he did in 3 weeks. That was a consolidative effort. And then because I'm in a busy clinical practice, I saw another case 3 weeks later. So together, that's a short interval. That's going to help my multiple myeloma knowledge go up. But if I did see a case recently of subarachnoid hemorrhage, and then the interval with which I see subarachnoid hemorrhage is once every 5 months that I'm primarily responsible for it, that one has less chance of sticking in long-term memory. Although if it's really memorable, maybe it will.
Yeah. So much to do. So to make the audience, actually to make me feel better about this, if I'm being honest, how much?
It's all group therapy, man. It's all group therapy.
How much time do I need per week to devote to this to really move forward on my path towards expertise or mastery?
Yeah. Okay. Fair question. I think that you want to be able to find 20 minutes per day minimum. And it can overlap with something you do. So, for instance, if you have an exercise routine, can you do it with that? If you have a commute, can you do it with that? If you're stuck waiting to pick up a kid somewhere, can you do it with that? Or somewhere where it's downtime. And you figure out your hacks. Like I actually, even in this electronic age, I carry a lot of these cases and stuff, like just printouts with me by paper. There's times when like you can't look at your device. It's not socially acceptable, et cetera. And I will pull out a piece of paper, which is much more acceptable, but I'm getting my reps in. I look at it like a gym. Just how many reps are you going to get in? So devote 20 minutes extra a day and ask yourself this: have I followed up on 2 of my patients? And have I put myself in front of 2 more cases than I would have? And they could be micro cases with micro learning. And then on any of those, can I do something that will consolidate that memory in the next couple of days? That's an ambitious goal, but it's also an achievable one.
Fantastic. Stuart and Paul, do you guys have any further questions before we let Gurpreet go?
No, I got some work to do, so I should probably. I need to go start reading some cases like Toot Sweet, I think.
At least 20 minutes worth.
At least.
Yeah, just 20 minutes.
Okay.
And maybe I don't know. This may not be. I mean, I should say if I sometimes try to describe my compulsion for this, I really do love it. I think that if you love medicine, then reading these cases, meaning these micro cases, it's a joy. You're someone else has done the work, and you're getting all the learning. And I would say, if I was even to describe myself, I sort of have a bit of FOMO. Like I have a FOMO of cases. I'm like, there's so many great cases in the world, or even in my local environment, and I'm not hearing about them. So I'd encourage you to have FOMO about cases. Maybe there's a hashtag about it.
Yeah.
We'll get our social media team on it too.
Yeah.
I want credit if that starts going viral.
Yeah. I think that's going to start trending. That'll start trending along with the hashtag Where's Paul, which is something that we started a while ago.
It's gone nowhere.
It's gone nowhere.
If case FOMO has more potential.
Yeah.
All right. Thanks, guys.
This is fun. I love the fact that we get to talk to you once in a while. This has been awesome.
Oh, I love it too. I got to tell you guys, like, this is the teacher in me, and I bet each one of your guests is saying this, whether they know it or not, is they're consolidating their knowledge. Like when you go on a podcast, there's the emotional valence of like, this is social, and this is public. Mm-hmm. So it leaves a strong imprint on their brain. Even if it's their usual teaching stick, I can promise you, like, I'm clarifying things in my mind because I'm telling you guys this. So I love it.
Gurpreet, we'll let you go. Thank you so much for your time.
This is great fun.
This is great as always.
I'm a super fan. I plug you guys anywhere I can. So I love your guys' shows. My favorite thing, which I listen to at the very opening, is this sped up disclosures, when you go through it. And my favorite one is where it says, like, does not reflect the affiliates of Cashlike, if there are any. There are none. You have to listen very closely. I don't know when you recorded it, but it's the sequencing of it is so hilarious.
That's Stuart.
I know it's Stuart's voice, I can tell, but the there are none.
Yeah,
I've meant to re-record that several times.
No, that thing's golden. I might stop listening to get rid of that. All right, fellas, I'm going to sign off.
All right,
see you guys later. Bye.
Yeah, Stuart, that is my favorite part of that as well.
All right, fair enough.
All right.
You want to do the outro?
This has been another episode of the Curbsiders.
It sure has.
Bringing you a little knowledge food for your brain hole. You can get
Yummy.
You can get show notes at thecurbsiders.com/podcast and get on our mailing list at thecurbsiders.com/knowledge food. Please give us your feedback. Send an email to thecurbsiders@gmail.com, or you can reach out on Facebook, Instagram, and on Twitter at The Curbsiders. Until next time, I've been Dr. Matthew Frank Watto.
And I'm Dr. Stuart Kent Brigham. And good night, Curbsiders. Good night.
Yeesh. And I remain Dr. Paul Nelson Williams, and good night.
Oh, hi, Paul.
And a special thanks to all our producers and writers for the show, as well as our social media team. Beth Garbatelli is on Instagram. Hannah needs a nickname. Abrams is on Twitter. And Chris Chu is on Facebook. Thank you and good night.